Well, welcome everyone tonight for our event on visual fields, glaucoma and beyond with our wonderful presenter, Dr. John McSoley. So we're so excited to have him. And I will be your host today. My name is Dr. Ariel Sorenzi. And then a little bit about our speaker tonight, Dr. John McSoley. So Dr. John McSoley is a graduate of the New England College of Optometry. And shortly after completing his optometric residency in ocular disease, he joined the optometric staff at Baskin Palmer Eye Institute, where he is currently the Associate Director of Optometric Services. He has lectured and authored articles on topics related to glaucoma. With his optometric colleagues, he participates in an optometric residency and student externship program and serves as an adjunct clinical faculty member for several colleges of optometry. He is a member of the Broward County, Florida and American Optometric Associations, and he is the founding member of the American Optometric Glaucoma Society. So thank you so much for blessing us with your presence tonight, and we're so excited to learn more about glaucoma.
Well, hello everyone. I hope you can hear me okay. Thank you for the introduction. And I think of it the other way. I want to thank everybody for coming on tonight. It's actually very, very humbling and very nice when a group of colleagues takes time out of their personal life and time away to try to invest in the profession to get better, but also to try to listen to me. I'm very humbled by that. I want to thank Dr. Wu and all her colleagues at Wu University, particularly Dr. Sorenzi and Ursula was helping me out earlier today. It's really a professional organization. I'm very happy to be part of this today. I also want to acknowledge Hiru for their unrestricted educational grant to support endeavors like this. It's important, and let's say a little thank you to them when you have the opportunity. I want to thank Dr. Eibach. I had the opportunity to listen to him last week, and I hope many of you also did. Very enjoyable and informative time together. And that's what I hope happens tonight. I'm grateful that you're here. I hope this is an enjoyable and informative time that we get to spend together. And I think there'll be some opportunity to ask some questions. There may be things that are not new that I tell you tonight. There may be different nuances that are different than you've maybe had them explained before. And hopefully at the end of the day, it's all productive. As I said, I have served as a consultant for Hiru. In recent time, I've served other capacities in the past for other companies. Now, obviously, you can read the course description. My purpose for really emphasizing some of the things today is that when you consider the decisions that we make on behalf of our patients based on the visual fields, it's actually a pretty profound impact on what we do for our patients. So I do think it's important to understand and make the best decisions that we can with the information that we have available to us. Now, this is an example of our traditional visual field printout. All of you are probably familiar with this. It's from the Humphrey Field Analyzer. And I know Dr. Eibach went through some details on these last times, but in a nutshell, we've got our reliability parameters in the upper left corner. We've got our threshold sensitivity values. Next to that is the corresponding grayscale. Below that, the total deviation and the corresponding probability plots. And next to that is a pattern deviation and its probability plots. The glaucoma hemifield test is on the right, and below that are global indices of the mean deviation and the pattern standard deviation. And I know that there are times when we focus on one aspect of the field or another, and many times we focus our attention on the pattern deviation, and it is a very, very useful tool. But I suggest that we do best when we understand the interrelation of all the parts of the field and what it means, and we can assign maybe a better level of value to the information that we have. Another example I'd like to use tonight is that of a Hiru visual field, where we can see it's perhaps a little bit different layout, but similar transfer of information. We've got some reliability parameters in the top. I've got my bar in front here, so I got to move that a little bit. Our fixation, which is, whether active track or blind spot monitoring, the different stimuli. Our reliability parameters are in the top. Our threshold sensitivities. Next to that is a corresponding grayscale. And again, below that, the total deviation, the deviation from expected values based on the person's age. And next to that is our pattern deviation as well. And I'll draw the distinction on both of these devices that the pattern deviation is different than the pattern standard deviation. PSD is not the same as the pattern deviation. And interpreting that, we'll have a couple pearls about that near the end we'll talk about. So what happened here? Forward. Okay, so why do we do visual fields? We want to identify an abnormality when there's some degree of suspicion, right? We want to explore some clinical findings we have. We may want to address patient symptoms. Or once we know there's a problem, once we know there's a diagnosis, we may choose to follow that person for either stability or to identify progression of the condition. Again, this has been talked about a little bit with Dr. Eibach, and I'm going to hope that many of you were on that last week. But basically, visual field assessment involves detecting a stimulus or stimuli against a background. This can be done with so-called kinetic perimetry, whereby a stimulus of a given size and intensity is brought from non-seeing portions of our visual field into seeing portions of our visual field. And the boundary of that sensitivity is determined, that's called an isopter, that's the unit. And I'll contrast that with, which is what probably more familiar with all of us, is static perimetry, whereby the stimulus doesn't move, but the intensity of the stimulus is altered to identify the level of sensitivity of that individual point. That unit is a decibel, and decibel really reflects how much of a reduction from the maximum stimulus for a given machine. Now, brand X is going to have a decibel on brand X does not equal a decibel on brand Y or brand Z. So each machine may have some nuances with it, but if we think of it in terms of the attenuation of how intense the stimulus can be on the machine, such that the higher the number, the dimmer the stimulus, i.e. the more sensitive the person is in that location. So as we approach going into tests, let's first talk about a few different things that might be obvious to us, but maybe nice to revisit. We want to select the appropriate test, okay? And this involves the right test pattern and stimulus size, et cetera. We want to recognize how good the test is. We want to look and reliably determine what the test shows us and what do those results mean. So a little bit more here. There were a couple of questions last week that I was able to see that we didn't really get time to cover, but one of the things that comes up often is, what is a -2? What does that really mean? When you say a 30-2 or 10-2 or 24-2 test. Well, the first number relates to the degrees from fixation, okay? And the -2 reflects the test pattern. There is such a thing, or there was such a thing as a -1 pattern, and those stimuli fell on the vertical and horizontal meridian. Now, we can obviously understand that because of many factors that we might lose a little bit of information by things bleeding over to one side or the other. So the -2 pattern straddles the vertical and horizontal meridian. So that's what that -2 means. We can talk a little bit about the different, test algorithms and test strategies, and that's really not the scope of our talk tonight. Suffice it to say that the difference between full threshold and fast pack and C to standard and C to faster, et cetera, those are important things to understand. But again, not really something we have the time to invest in tonight. But I would suggest that each of those has some nuances that are worth trying to grasp and be familiar with the tests that we perform for our patients. Size 3 and size 5 stimuli just obviously relate to the different stimulus sizes. So once we select the appropriate test for the clinical question at hand, we want to be able to assign a level of diagnostic value to the test, the information that we get. So what do I mean by that? Well, when we assess the results of the test, we'd like to know, how good is this information? So for example, is the test reliable? Can we place, or what level of confidence can we place in the results? We look for things like how well did the patient perform? Did they introduce any artifacts or things that might mislead us? When we talk about reliability, quickly we jump to things, the reliability parameters, false positives, false negatives, fixation. And I know Dr. Eibach did a discussion on the false positives and false negatives last week, which I won't reinvent. Suffice it, The false positives are when a person responds when there's really not a stimulus to respond to. This is a patient that might be either trigger happy or anxious to get the test done, but they're responding at times when there's not a stimulus to reliably respond to. And a false negative is when a patient fails to respond to a stimulus that they really probably should see. And that might be based on their previous sensitivity levels or previous points that were thresholded. But when they don't respond to that, it speaks to a couple of different things. And one is patient attention and reliability. But as we'll see in a future slide, false negatives may also be affected by the status of the visual field itself. So for fixation losses, we'll spend a minute or two on that. And I think we're all familiar with blind spot monitoring, whereby a stimulus is presented to the location of the blind spot. It would make sense that if the blind spot was determined and then later a stimulus was seen, that the blind spot had moved and the patient had changed their fixation. Another way fixation can be monitored is with a so-called gaze tracker. And this example comes from our Humphrey Field Analyzer, where across the bottom of the printout, when it's enabled, you see this plot that's displayed on your screen. And this uses the position of the corneal light reflex with respect to the position of the pupil, such that you'll see upward deflections are times that fixation moves. So the bigger the deflection, the larger the excursion of fixation. Downward deflections are times when fixation could not be identified. So you can think of things that might interfere with that. And one might be the lid could droop down such that the lid margin blocks light reflex. The patient may move back from the machine a little bit or change their position. So all of these things can impact the ability to identify where fixation is. I'll also make the point to mention that as we see this, we see that this graph goes from left to right, and the left is the beginning of the test. And as it proceeds through the course of the test, it moves to the right. So if I could just put on the clinical hat for a second and say, well, what happened here? There was a point in the test where fixation could no longer be determined. And that was probably the latter half of the test. And if we accept that maybe the eyelid had drooped down to block the corneal light reflex, then it would be reasonable to think that the points that were tested later in the test, the peripheral points, were actually maybe impacted. So if we saw a superior depression with this gaze tracker, we may not have a lot, we may understand that it's probably an artifact. Now, some of the newer devices, like the head-mounted devices, such as this example from the Hero, will monitor fixation continuously. And in this example, not the gaze tracker, but the active track, that will actually monitor fixation continuously, and it won't present stimulus unless fixation is correct. So you have some degree of confidence that while the test is being performed, the patient is fixating correctly. Some other things to keep in mind as we approach our visual fields. On most test strategies, the foveal threshold is determined early. Later, so-called primary points, or some refer to them as seed points, are tested early on in the test. Based on those levels, adjacent or nearby points have starting points to start their thresholding strategy, however they progress through the threshold, such that central points are then determined, and the test moves peripherally under most circumstances, so that the peripheral points are tested later in the course of testing. Now, instruction and patient participation is always important and will translate to better results, across the board. I would submit that, especially with the faster algorithms like the CETAs and the CETA Fasters, for example, that you really want to get off to a good start. You want the patient to do well because the efficiency of the test really depends on accurate responses. Okay, so the role of the patient's participation is important. And again, as a doctor, you want to understand the pattern, the sequence of the testing, and how can we minimize poor test results. Some other things to keep in mind, and this might be self-evident, but sensitivity tends to decrease. Our values go down in the visual field, of course, as we go eccentrically, right? So as we move away from the fovea, away from fixation, values are lower, but they also diminish with longer test time. In addition to that, variability, the ability to perform the test and get the same result, how consistent the responses are, that tends to increase. So it becomes less consistent the further you go from fixation, the longer the test takes, okay? And also when you get to the moderate levels of sensitivity, and I'll go back to what I said about the false negatives a few slides ago, when I mentioned that sometimes false negatives indicate an issue of reliability, but sometimes they can reflect the status of the visual field. And when you have the mid-level sensitivities, those points tend to be more variable. They tend to fatigue more readily, and therefore you're going to get less consistent responses in those points. Another way to say it is normal points tend to be consistent, and very bad points, your zeros, tend to be very consistently poor, but it's the points that you're really trying to follow for change, the abnormal points, that might be more variable. So this is an example of a visual field that I think we can recognize. Move this. I have something in my way here. All right, guys. So I think you can recognize that when we talk about the primary points were done, and later on in the test, we have some pretty poor, low peripheral sensitivity values. Now you can think of things that might give you that type of feel, pan-retinal photocoagulation, RP maybe, but not really, right? This is an artifact, this is an edge artifact from fatigue. And what helps support that is the long test time of over 9.5 minutes, right? And also the high false negatives that we see of 46%. So we can recognize from this, that this patient became very fatigued, became very inconsistent in their responses, and that led to the longer test time, such that the points that were tested later in the test, the more peripheral points, were abnormal. So what are good reliability parameters? Where do we set our goalposts? And the answer to that is it's really not absolute. It's a continuum. The lower, the better. The lower it is, the more confidence we like to think that we can place in the data that we receive. Now, one of the biggest things to speak to reliability and confidence has to do with the clinical picture. We have this perception of our structural and functional correlations such that if we see a defect on a nerve that's superior, we expect the corresponding field defect to be inferior, correct? So if I were to show everyone in the audience this picture of an optic nerve, you say, well, you've got a large disc, you've got a vertically oval cup. You could argue the inferior temporal rim is thinner, and you would be correct. But what I hope you see also is that there's a nerve fiber layer bundle defect that extends down from the inferior temporal part of the disc. So I think everyone on this call tonight would say this is probably going to result in a superior nasal or superior arcuate defect. So the biggest thing we want to know is, does it make sense? Is it what we expect? Do we need to re-examine the patient? Is there something that we missed? Do we need to repeat the test because it doesn't add up? If we consider the sequence of testing, the points that were tested later, the points that were tested first, patient instruction, test time, patient's comfort and understanding, how well did they perform the test? I think we can learn a little bit from that. Keep moving this thing to get it out of my slide there. Okay, so here's an example, and we already seen the slide on the right with the edge artifact, that clover leaf pattern, and the slide on the left, which is a more dramatic form of really the same defect, right? So the first 4 points, those primary points, were determined, and then for whatever reason, the patient decided that they weren't going to respond for the rest of the test, and that's what we're left with. Now, if you look at the other reliability parameters, what you might find interesting is fixation losses aren't too bad at 2 out of 24, and false positives are good at 0 out of 12. So one might be tempted to say, well, the test looks pretty reliable. However, when we look at it in terms of the big picture, if a patient stops responding, period, they're not going to have false positives. They're not going to have fixation losses because they're not responding anyway. So anyway, I thought that was maybe illustrative. So last point I'll leave you with there, the peripheral points are tested later in the test. These cloverleaf patterns, really a fatigue effect, edge artifact. It's not a lens rim artifact in this situation. Oftentimes you'll see high false negatives. You'll see longer test times. And if you ask the patient, they'll say, I really didn't do a very good job today. But it is important to recognize these things, right? Because the quality of the visual field will impact how valuable it is to us diagnostically. Let's recognize the reliability. Let's look for possible causes of artifact. Let's ask the patient for their input. And certain things that might maybe not seem so important, like alignment. You could actually, and you can probably do this yourself, if you turn your face slightly, you can actually cut off part of your nasal field by just turning your face a little bit. And that may or may not be identified by losses of fixation, right? So head and body position are important. Instruction, it's worth having your field techs really run through things in a very positive way with patients. Okay, media, the correct refractive error. Occasionally I'll have a patient that started out at a +4 refractive error, and then they had their cataract surgery and their plano. Well, if you do a +4, and then if you're using, for example, a Humphrey, where you're adding the distance of the bowl, all of a sudden you're doing a test that's 3 or 4 diopters more than you need to, and that can have a profound impact on the sensitivity of the visual field. Other artifacts that are important to recognize. Now, I put these in the artifacts not because I think the patients are bad at doing fields, or because the techs aren't doing their job, or the devices are substandard. On the contrary, I put them in so that we can recognize what they are and maybe either work to avoid them or recognize that the information they're giving us are flawed, and then maybe repeat the test in better circumstances. And this is an example. This is one of the head-mounted devices whereby you can see there's this band across the top of the field. This is the type of artifact that's sometimes seen in these tests when there's some light leakage from the edge. Maybe the light shield is improperly positioned. And when that happens, you can sometimes see defects like this. I've also seen defects that are vertical in this type of thing that disappear on repeat. I guess the value is recognizing, oh, this isn't useful information. Let me repeat the test. Here's an example of a super threshold test that really 2 times the headset was malpositioned, and then when it was correctly positioned, those abnormal points, those horizontal bands of abnormal sensitivity improved. Here's another example of a type of artifact that I don't think would fool anybody here, right? It's obvious, where we don't generally get these white scotomas on the grayscale, where the sensitivity value is sky high. We're seeing 50 and 49 decibels. We see reliability parameters that are really nothing to get happy about, right? 14 out of 17, or 33%, et cetera. So when we see this, it's easy to say, okay, well, clearly this wasn't a very reliable field. The patient was a little trigger happy, however you decide to label that. But here's another field that might fool us because it's really the same artifact, only a little bit more subtle. So we've all been accustomed to thinking of the pattern deviation as the sort of the summit of the visual field information. And I think that we can't interpret that in isolation. It needs to be interpreted in the context of the entire field. And when we look at this, we could say, and we can talk about, whether that's a cluster defect or whether that's at the beginning of a field defect. The question could certainly be raised. What's interesting is how much worse that is compared to the total deviation. So let's spend a minute talking about the pattern deviation. I think the pattern deviation is important to discuss for a few different reasons. One, many of us emphasize this in our interpretation, myself included, but many of us emphasize this in our interpretation. Secondarily, the glaucoma hemifield test, which is very sensitive for detecting subtle differences across the horizontal, uses the pattern deviation values in its calculation, right? And then thirdly, the progression algorithms that are commercially available also use a pattern deviation. So if we introduce an artifact in the pattern deviation, those artifacts are likely to manifest further down in our interpretation. So how does this happen? Well, remember, the pattern deviation is designed to identify localized areas of abnormal field within a field that might be generally depressed. How does it do that? Well, it takes the 85th percentile point, which is the 7th most sensitive point. It adjusts that level to 0, and then it subtracts that value over the entire visual field. Now, most of the time when that happens, it's subtracting a negative number, right? Because most of these fields that, they're not perfect, they're 0 or a negative number. But so effectively you would add some sensitivity to the pattern deviation. But in cases where that 7th most sensitive point is a positive number, you're actually subtracting things from the entire visual field, and you would theoretically make normal points look worse, and the abnormally high points would appear to be normal. So the goal of the pattern deviation is to identify a localized defect within a field that may not be normal to begin with. So when we look closely at our previous example, I think you can appreciate that we can either do from point to point. So if we take this point of 0 and the corresponding point on the pattern deviation is -5, or this point is -1, and now it's -6, we can pretty much sense that, okay, the 7th most sensitive point is probably a 5. And if we start to count them down, you don't have to do that exercise, but you get a 12, you get a 6, you get another 6, you get a few 5s, you get another 6. The 7th most sensitive point is a 5. So basically we're lowering the whole field and we're making points look more abnormal than they really are. Now let's look at what the actual values look like. And I think if I said to you, these 32s and 33s and 31s, do they seem normal to you? Yes, they do. Okay. But what isn't normal is way out here in the periphery, we've got a 37, we've got a 35, we've got another 35. So what's happened is the sensitivity of the whole field was artificially lifted because of those outlier bad points. Now, how did this happen? Well, we look and we say, well, fixation losses, well, there's only 7 out of 14 fixation losses. That's true. The gaze tracker was also turned off on this patient. So it wouldn't be such a stretch to imagine that the patient was kind of putting their fovea out here and seeing points because they were anxious to get the test over with, right? These points are tested later in the test, and their patient starts hunting for points to get the test over with. That's a reasonable conclusion. Okay, so when we look at the whole thing all together, we see the gaze tracker's off, fixation's not perfect, we have some high sensitivity values, we have a positive mean deviation, and the total deviation, pattern deviation, instead of being a positive number, is a negative number. Okay, so I guess, I don't know if this is a point to maybe see if there's any outstanding questions, any things there's probably a few things I did not explain well. If there's things that are worth talking about, I'm very happy to take some questions now. If not, we can continue on and blaze through the rest of the material.
I think that you've done a wonderful job explaining it, because we do not have any questions right now. And then we'll answer any that we have at the end.
Okay. Is everybody still awake? Can you see them?
Oh yeah, everybody's.
I could not have explained it that well. So it's like a feat of impossibility for me. So
I think you're crushing it.
I'll press on. However, if their questions do arise, please feel free to chime in, and I'll do my best to answer them. So I've sort of focused on more general and the applicability of visual fields to glaucoma, which was not the only part of the talk tonight, right? There was things about glaucoma I wanted to include. There were things that we need to move on from that. It's vital to glaucoma. We use it to help diagnose the condition. We use it to help stage how much damage there is, and in the course of follow-up. But there's other very important field use in non-glaucomatous conditions, and we can do that to address symptoms, follow up on signs that we uncover in our exam, whether that's the level of vision or color vision or visual field defects that we get on whatever screening techniques we use, including confrontation tests. Sometimes the fundus will steer us that way. Sometimes history or suspicion, whether there's potentially a compressive lesion in the visual pathway or pituitary tumors, history of stroke, certain drug toxicities will prompt us getting visual fields. So I think there's a lot of reasons to do visual fields, even beyond glaucoma, which is near and dear to me, but it's not the only reason to do a field. So a quick review, and again, this is going to pale compared to what Dr. Eibach did with his sketches and drawings last week. So I actually removed some of those because I don't think I could have explained it any better than he did. Basically, the retinal nerve fiber layer arises from the ganglion cells in the retina, and it travels across the retina to the optic nerve and then proceeds posteriorly through the optic nerve, through the scleral canal. And those optic nerve fibers go back to the optic chiasm. We recognize and we all remember that nasal fibers cross at the chiasm and temporal fibers stay on the same side. So it makes sense that the temporal fibers of one eye and the navel fibers of the fellow eye go back from the chiasm along as what's called the optic tracts. Now, the optic tracts proceed to the lateral geniculate body, and they synapse in the LGN, or the lateral geniculate nucleus. From that point, and that's one cell body from the retina all the way back to the LGN. Okay. From that point, after the synapse, the neurons then proceed posteriorly back towards the visual cortex through the optic radiations. Now, the inferior fibers pass through the temporal lobe and superior fibers pass through the parietal lobe, heading towards the occipital lobe where the primary visual cortex is. I don't think I've told you anything new yet, and maybe not at all. So maybe some things to consider with our visual field defects is that commonly we'll get monocular defects, whether that's glaucoma, whether it's macular degeneration, whatever the reason. We recognize that some monocular field defects will be present in both eyes for bilateral conditions. Okay. There may be conditions that are anterior to the retina. These defects tend to be more diffuse, whether it's medial opacities, bad refractive error, etc. Retinal vascular defects, nerve fiber layer defects, some optic nerve defects tend to respect the horizontal. Okay, especially in the nasal visual field, right? So the temporal fibers, because of their anatomy, those defects tend to respect the horizontal. Some nerves and some macular condition will affect the central visual fields, of course, and then other defects in the field should correlate anatomically. You know, you've got retinoschisis, you've got RPE disruptions that may manifest with visual field defects, so it should make sense. Now, binocular defects might be a little bit more rewarding in this part of the talk because it follows with the visual pathway, right? So because of the crossing the navel nerve fibers, we can localize bitemporal visual field defects to the area of the optic chiasm. Okay. Beyond posterior to the chiasm, because of the way the fibers are represented on one side or the other of the vision, a defect will be manifest based on that. So say another way, the temporal defect that respects the vertical in one eye and respects the vertical in the other eye, that or more, if it can go across the vertical, it might even involve visual acuity. Those are so-called junctional scotomas. Okay, so you've got the temporal defect that hits those nasal fibers, but then it's a little more anterior, so you're catching more of the fibers of the other eye. So you've got one eye more extensively affected and the other eye with a temporal depression. Defects that are on the same side, okay, suggests that same side of the field in either eye suggests that the lesion's posterior to the chiasm, right? And that's going to be in an area contralateral to the visual field defect. The lesion will be contralateral to the field defect. Remember that because the inferior fibers pass through the temporal lobe, superior field defects tend to be from the temporal lobe, and inferior field defects corresponding to the superior fibers tend to be in the inferior field. Generally speaking, the more further you go back, provided you don't have a complete hemianopsia, but the more further you go back in the visual pathway, the more similar or congruous those defects are in their shape. And again, occipital lobes lesions tend to be very congruous or very similar in their manifestation. So here we can see a patient that is a glaucoma patient, but yet came in with a new visual field defect. And I would submit to you, and I think all of you would recognize immediately, this is not a glaucomatous visual field defect. Not by its pattern, not by its onset. We don't expect to see an inferior temporal field defect when the nasal field is pretty normal. I suppose it's possible, but it's not likely. And even this characteristic of the visual field defect, it is in this sort of wedge pattern, very, very deep at levels of 0, where the other points that we might expect to be preferentially involved also are much higher sensitivity. So again, this is a quadrantic defect here. And actually extends up a little bit, respecting the vertical midline. This is an example. This is one of the head-mounted devices, a HERO visual field, where we can see the bitemporal depression in a patient with a known pituitary tumor. This was known. Okay, so shifting away from some of the other things we might encounter, and let's talk about following up with our patients. And this is, I would argue, even more important and more challenging. It's one thing to identify a defect in patients. It's another thing to identify whether a patient is getting worse or not. And some of the things that I like to stress to people when I talk about this is that you can have a real decline in the normal range. So you can have points that appear to be normal, but yet still worse than what they used to be. You can also have points that are normal to begin with and then get worse. And there's an example of that I think is going to be pretty important to recognize, okay? And then you can have artifacts that look like the field is worse, but yet they're artifacts, and they need to be identified so you don't automatically assume that people are getting worse. So let's look at that a little bit further. This is an example of a patient. We see the slide on the left compared to the later performed visual field of the slide on the right. And I would, at first blush, you say, wow, that arcuate defect has moved closer to fixation. This is really pretty concerning. This patient appears to have gotten worse. But if we look at it carefully, I think you can appreciate the arcuate characteristic that's present in this field, right, is really preserved in this field. It's just that the whole field has been shifted down. And this is one of the ones when I looked at it and I asked the patient, I said, well, how'd you feel during the test today? I didn't feel like I saw it very well. I didn't think I was in the right position. So again, it's helpful to have the conversation with the patient about these. So here we see a visual field defect that appears to be worse. I think we can identify the artifact. And in fact, when this was repeated on subsequent fields, it reverted back to this field, right, that it was before, and she was in fact stable. Another concept is once a point is statistically abnormal, you need to follow the actual sensitivity values. You can't rely on pattern deviation or probability symbols or things like that. Another important thing to consider is that the PSD, or the pattern standard deviation, which is one of those global indices, right? We have the mean deviation, which I think we're all familiar with, but the PSD is meant to assign a level of unevenness or how focal is the defect. Ideally, the bigger the number, the more focal the defect, the worse the defect. And it's very useful early in the course of the disease, okay? But it makes sense because it assigns a value about the focalness, if that's a word, of the defect. As the field gets more and more diffusely involved, right? The defect may become more extensive. The focal nature becomes less of a feature, so that it would be misleading to look at the PSD as the field becomes more diffusely involved, because it can actually be deceptive, right? So the focal nature will become less abnormal as more of the visual field becomes involved. I hope I explained that fairly well. So basically PSD useful early, uses some of its utility later in the course of the disease. And the other concept I'd like to maybe mention today is that you need the range to detect somebody getting worse. At some point, you're going to hit a floor or a pedestal, and you're not going to be able to know whether the patient's getting worse or not. Sometimes you test other parts of the field. Sometimes you might increase from a size 3 to a size 5 stimulus. Sometimes you just recognize that this part of the field, I kind of accept I'm not going to be able to monitor as closely as I'd like. But you need to have a range to identify somebody actually getting worse. You don't want to look at a bunch of zeros over 10 years and pat yourself on the back because they're still zeros, because you have no way to know whether they're really worse or not. We get a lot of this concepts that are easy to illustrate with our imaging devices, right? So for example, on an OCT, you can have somebody that diminishes their RNFL thickness, but stays in the green, right? Stays in the normal range, right? And then once somebody turns in the red zone, you can still have somebody get worse. You have to follow the numbers, right? But there's a certain point where you reach, and that might be, say, 50 or 55 on the RNFL, where you can continue to get functionally worse, but yet you can't measure it with that particular device. So some of the analogies I think hold up, and they're important to recognize. Again, test selection, decide what you're going to follow, and decide what's going to be most useful for you, for your individual patient. Again, not really the scope of what we want to talk about tonight. I thought this was an interesting example, and I included it because it illustrates my point about not counting the black boxes. So if we look at this series of 5 visual fields, I think you can look at the grayscale and say, okay, something definitely is going on here, right? This seems to get a little bit worse. But if you look at the total and the pattern deviation probability plots that are included in this overview printout, we say that it roughly stays the same, right, over time. So this stays, you might have 1 or 2 points that are different, but basically these are staying about the same through the series of visual fields. So if we relied on that to say, well, it looks like it's pretty similar, it's just the same pattern, it's almost superimposable, hold the phone. Let's look and see just what is what are the sensitivity values? So even though they're statistically abnormal, they continue to progress even lower. So we have points in the low 20s, points in the teens, points in the zeros, and then all the points in the zeros. So if we can't afford to only look at the symbols, we have to actually look at the decibel values once something's abnormal. Determining progression, general concept, it depends on how good your baseline is, how variable your patient is, how good is the individual test that you're performing, okay? How reproducible is it? Is it good across the spectrum of the disease? Does it work really well in early disease, but poorly in mid and late disease? What's the dynamic range? Do we have the ability? Do we have a step or two to measure somebody getting worse? And of course, how often the patient is tested. So what's the role of field testing? And we're coming to the home stretch, and I appreciate everybody hanging in there for all this tonight. You explore the suspicion that you have. I mean, I'm not telling you anything new. That's why you do fields, and it helps you with your diagnoses. It helps you stage the condition. How badly is this person doing? And glaucoma lends itself well to this, but yet we may follow people for improvement on other conditions with the visual field. While we have the responsibility of caring for our patients and with potentially sight-threatening conditions, we want to monitor them carefully for change. We want to identify if they're getting worse, and we also want to be able to confirm with a level of confidence that they're stable, right? We want to be able to reach the patients that might have trouble. We want to be able to identify artifacts and try to minimize the things that are, sort of the things that distract us from the point at hand and how well we can follow the patients. So I want to thank everybody for being on this long. I appreciate your patience. I know on the East Coast, it's late for a lot of you. For the West Coast folks, you're coming off the end of a workday and you're jumping on this call. I sincerely hope it was productive and worthwhile for you. I want to thank the meeting planners and everybody involved. And I also want to just acknowledge all the scientists, the clinicians, the staff, the patients, everybody that kind of participates in this to help us all do a better job taking care of our patients. So I thank you all, and I hope this was a pleasant evening for you. And here's our last slide. Stay tuned for next week, and I'll let Dr. Sorenzi kind of expand on that.
All right. Well, thank you so much for the awesome presentation. We had lots of questions flood in after our halfway point. So we'll start with a couple of those. One of the questions was about concussions, and if you run a visual field, would that show up with any type of defect?
That's a great question, and I'm not really sure. I tend in the patients recently that I've encountered with concussion, I've not done fields because I don't know how their visual symptoms and pathways are going yet. And I don't necessarily want to aggravate a situation. And I think there's plenty of time to assess that. I don't know. I think the other symptoms are maybe would take precedent over that. I certainly wouldn't want to, just like they say, avoid computer use. There's certain things that you want to do. I'm by no means an expert on head trauma, traumatic brain injury, and I probably would have one of my colleagues, one of my optometric or ophthalmologic colleagues look at that patient. If someone has different information, I'd welcome hearing about it. But I don't use visual fields as a first line in assessing that.
And how do you feel about headaches kind of along the same line? Is it kind of a similar scenario?
I think that, so the yield is probably going to be not super high on fields. However, I think we should have a low threshold for performing visual fields, and sometimes things will show up. Sometimes things that are otherwise asymptomatic have a big arrow pointing to them after a visual field. So I have a low threshold for performing visual fields in headache patients, but I also look for other neurologic or visual symptoms that help me sort of think along those lines. I don't think you're ever wrong to get a field, particularly if the cause of the headache is elusive.
Okay, great. And one of the questions was about insurance. And if you have an unreliable field, can you technically bill for that?
Yeah. I think you can bill for it, and I think you can get paid for it, but I don't know if you can get away with it long term. So, our third party people say all the time, you can you can bill for anything you want, but it doesn't mean it's legal or ethical. So, but that's another question. I think you could probably get the first one, but the repeat field is where it may be flagged. I don't know the answer to that. I think if you just want to do right by the patient, you got to do the field again anyway. And however you decide to do that is the way to do it. I know everybody's got a family to feed or bills to pay and a staff to pay. So I think that's an individual decision you have to make. I usually make sure that if the field's done poorly from our perspective, if we did the wrong field, or if for whatever reason, then I feel a little bit ethical. I don't really charge that patient for that field, but I repeat the field and do it right, and then I would submit the charge for that. Yeah, if the patient's if it's part of the clinical care, and that's the nature of this particular patient or the status of their eye condition, I would submit. I don't know that third-party payers are going to agree with me, but I would submit that it's probably justified because you need it for the clinical care of the patient.
For sure.
And I'm not making that decision, so.
And so kind of along that same line, when you had the patient come back, about how long would you typically wait?
Great question. It really depends on the condition the patient has. So, the question I'll sometimes, say to former students or, residents or something is, what's the cost of being wrong? If you're wrong, if this is real, are they going to lose their vision? Are you splitting fixation? Or do they maybe have a point at the top of the field that might not even matter? So that might depend. Is their pressure really high? Is their nerve really, really worrisome? Much like we do every day in our practice. Those of you that see patients with keratitis, I mean, you ask yourself all the time, how often do you see the patient back? It really depends on the clinical circumstances. So if it's an artifact, it depends on my level of suspicion. If it is highly burdensome for the patient, I try to do it at the next schedule interval. Sometimes patients are elderly, transportation concerns. You want to be really economic in their time coming in, but it's a hard question to answer. It's a good question, but it really depends on the needs of the patient.
Sure. There's a lot of counseling that goes into that too. It's like, oh, you want me to take that test over again?
Yep. And Dr. Stearns, you make a good point. If I could expand on it, one of the things that does seem to be that patients respond, they take their cues, and I forget where this is a study that I read. Patients take their cues from the doctor. And if the doctor's like, I'm really sorry you have to do that terrible test, that's a much different response on the part of the patient than when the doctor says, the fields aren't enjoyable, but they're so important for assessing where you stand. And if you really put a positive light on it, they tend to perform better. And I think that's been shown at least one paper that I read a long time ago, and I've tried to incorporate that in my practice.
Oh, that's really interesting. Yeah, that's something that we could all take home, because sometimes I call it a torture device. Yep. Another question that we had kind of along the same lines is for insurance is if the threshold FDT 30-2 would qualify as a 92083.
I believe it does because it thresholds. The 92082 are super threshold and single stimulus, and the FDT matrix. I assume that's what you're talking about, FDT matrix. That is a threshold visual field.
Okay.
There may be other considerations to go with that, but I believe that is a full visual field.
Great. And then do you feel that the virtual reality type of visual fields are as reliable as the Humphreys?
That's a great question. And so I think it has a very definite role. And I think that, I think you're going to see this coming out in some papers that are along the line, that it performs pretty favorably with that. Now, you're always going to get your outliers on both sides. So not every single person is going to respond the same way. As reliable that's a good question. Is it going to be as reliable? It may be more reliable in some patients. It may not be as reliable in others. It's still new. We're still learning about it. It's an exciting time. I think that you're going to expand your people you are able to do fields on by the increased flexibility that a device might offer, right? Patients that otherwise may not be able to get in for the field, or patients that, remote areas, et cetera, et cetera. So you might be casting a wider net. And if that's the case, you may get more outliers that you just interpret it within the context of what you're measuring. So stay tuned for that. That's a great question. I think it's a timely question. I'm optimistic.